So the first step in treating sleep-disordered breathing is identification of a sleep disorder, specifically with their breathing. There's two different routes that this could happen. They may go to their primary care physician, and the physician should be asking them questions about their sleep, find out if there is a history of snoring or excessive daytime sleepiness. They're also assessing for the presence of obesity, retrognathia, that's where they have a very small chin that is back towards their throat, and if they have hypertension. Those are all symptoms that correlate well with obstructive sleep apnea. So the other option would be to speak with a sleep specialist and have an evaluation with them. And they could do a comprehensive sleep history. They're going to evaluate any secondary conditions caused by OSA, for example, hypertension, coronary artery disease, etc. And then they're also going to do a physical exam. So when you ask yourself, what is a sleep specialist? This would be a physician who has taken their test, and they are considered a sleep specialist. As opposed to your general care physician, they typically are a family practitioner. Sleep specialists typically are pulmonologists, although that's not always the case. Let's go on to our next slide. So what are they looking for? Both, regardless of which route you go, they're both going to be assessing for mostly the similar things. With the comprehensive sleep history, they're looking to see if you've had any witnessed apnea, meaning does your spouse or family member or friend ever notice you stop breathing while you sleep? Do you have gasping or choking at night? Do you wake up in the morning and have headaches? Do you have a nocturia? That's where you need to urinate during the night. Do you have insomnia? Do you have sleep fragmentation? And do you have difficulty concentrating or remembering things? Along with this is they're going to do the Epworth Sleepiness Scale. Anything above a 6, remember, is considered to be indicative of mild sleepiness. Then they're going to evaluate what we call comorbid conditions or secondary conditions that can be due to sleep apnea, and this would include hypertension, stroke, myocardial infarction, that's a heart attack, cor pulmonale, that's right-sided heart failure, and car accidents. With their physical exam, they're looking for obesity, especially in the upper body. They're going to look for other features which suggest OSA. One of the primary features is neck circumference. In men, they're looking for a neck circumference of greater than 17 inches, and in women, it would be greater than 16 inches. That is highly indicative of OSA, or obstructive sleep apnea. BMI, they're looking at greater than 30 kilograms per meter squared. They're going to look for a Mallampati score of 3 or 4. And that is looking in their mouth to see how much of their airway is obstructed. Retrognathia, again, that's where they have the very small chin that is positioned further back in the airway. Peritonsillar narrowing. Macroglossia, that's where they have an enlarged tongue. Tonsillar hypertrophy, that's where their tonsils are swollen. Looking for an elongated or large uvula. The uvula is the little dangly thing in the back of your throat. And then they're also looking for nasal polyps. Let's go on to our next slide. The next step in treating the patient for sleep apnea or sleep disordered breathing would be doing an objective sleep evaluation. This could be a home sleep test evaluation, or it could be the gold standard, which is polysomnography, and that would be the sleep test performed in a sleep disorder center. With home sleep testing, this is indicated for those with a high pretest likelihood of moderate to severe OSA. So some of the factors they would take into account for this is someone who's obese, has a large neck circumference, has witnessed apnea or snoring, complains of gasping or choking at night, things like that, where they have several factors that suggest they already have sleep apnea. Now, home sleep testing is not indicated in those with the following comorbid conditions. If they have moderate to severe pulmonary disease, this could be emphysema, COPD, chronic bronchitis, interstitial lung disease, any of those. If they have neuromuscular disease, an example would be ALS, Guillain-Barré syndrome, myasthenia gravis. None of those are indicated for home sleep testing. If the patient has congestive heart failure, it is not indicated to do home sleep testing. If they have suspicion of a comorbid sleep disorder. For example, if they suspect the patient has hypertension, they would not be indicated to do home sleep testing. And also, if the patient is doing a pre-op evaluation for bariatric surgery, they cannot do home sleep testing. So basically, your home sleep testing is for people who have not developed any other comorbid conditions yet, but they have several symptoms suggesting they have sleep apnea. Now, on the other hand, we have the gold standard, which is polysomnography done in a sleep disorder center. Anyone who has symptoms and signs indicating a possible sleep disordered breathing can have this test done, and it doesn't matter what comorbid conditions they have. This is the safest method for sleep testing, and it's because it's continuously monitored by a credentialed healthcare provider. The only problem with this type of testing is sometimes insurance refuses to pay for it. So that just varies year to year and center to center. Let's go on to our next slide.
Just to review the severity of apnea, we covered this last quarter, but we have the apnea-hypopnea index, and that consists of all apneas and all hypopneas. Add those two together and divide that by how many hours of sleep. Based on the AHI, determines the severity. So a mild AHI, you can see down below, is 5 to 15 respiratory events per hour of sleep. A moderate AHI is greater than 15 to 30 respiratory events per hour of sleep, and a severe AHI is greater than 30 respiratory events per hour of sleep. Now, you will also see the term or abbreviation RDI used, and it stands for Respiratory Disturbance Index. And the way that that is different from the AHI is that that includes respiratory related arousals. Those are the respiratory events, remember, that are 10 seconds long. They are very similar to a hypopnea. However, they end in an arousal, but they do not have a 3% or greater oxygen desaturation. So some people, especially women, tend to have a higher RDI than men, whereas men tend to have a higher AHI, if you were to compare. PAP therapy is the primary treatment for sleep apnea. Typically, when a patient is diagnosed, they will try CPAP first. That stands for continuous positive airway pressure. However, auto-PAPs have become more popular and have found to be just as good as CPAPs. If a patient cannot tolerate CPAP or auto-PAP, they may progress to what's called bilevel PAP. And then two advanced types of PAPs are VAPS, which is variable adjustable pressure support, and ASV, which stands for adaptive servoventilation. The last two that I just mentioned, those we're going to cover later on in this course, but those are more advanced modes, and that's typically reserved for people with bigger breathing problems than just sleep apnea. There's different dental devices that could also be used. You see outlined in yellow in the top, those are the tongue retaining devices, and the thought behind this is that they have a device that sticks to the tongue. It works like a suction cup, and then it actually pulls the tongue forward, trying to open up the back of the airway. Then there are also mandibular advancement devices pictured below, outlined in red, and you can see that on the picture on the left how it's trying to open up that back part of the airway. The picture on the right you see is what a device would look like. So this is a device that actually fits in your mouth, on your teeth, and then based on this way the dentist sets it, it pulls your mandible forward. Dental devices are also called oral appliance therapy, abbreviated as OAT. There are surgical options if people want to go that route. There's different nasal reconstructions they can do. Maybe they have some nasal polyps, maybe they have a deviated septum. The turbinates up in the nose, they can even grind those down a bit if they're too big. Pharyngeal surgery, I think the most common one is probably the UPPP, which is pictured on the top there. your book will go over these more in depth and you can see the actual words, but if I try to say those, what those abbreviations stand for, I'm going to butcher it, so I'm not even going to attempt it. But notice on the before how narrow the back of the airway is, and then after they do the surgery, they have opened it up. They've gotten rid of all the tonsils, the uvula, and maybe some of the palate. And then there's maxillomandibular advancement, MMA. And you can see pictured on the bottom there, what they do is they actually go in and they surgically move the mandible forward to open up the back of that airway. And you can see again the difference in the airway opening in the pictures there. The most new of devices is the nasal expiratory resistors, and these are kind of cool. They're kind of like a band-aid material, and it just sticks to your nose, so you use one a night, put one on at night, and then the next night you need a different one. And the clear part right in front of the nares, their nostrils, air can very easily pass in when a person breathes in through their nose, but then when they go to exhale, it creates some resistance to increase the pressure in their airway and try to hold open the airway that way.